72 hours and they're shipped home. And so, people that are in the skilled nursing facilities used to be, they would stay there for weeks to months. And now it's a much different situation that the level of acuity there is much higher. And the idea is get them in and get them out. And, Medicare and insurance companies have kind of changed the rules of the game that says that while we're shortening the stay and raising the level of acuity, we're also finding that we're getting penalized and they're starting financial penalties for people that are returning to the hospital if they're too sick to be in the home environment or in the skilled nursing environment. So now continuity of care, which is really kind of the core subject matter, has been something that really helps make or break this outcome. And of course, the pandemic has presented us with a new set of problems because people don't want to go to their doctor's offices, they don't want to go to the hospital, they don't want to go to the clinics. But we also have some new tools, and specifically telehealth, which is how we're all sitting here on Teams, and sometimes it works and sometimes it does not. So, but anyways, I want to start out by asking each of the panelists, and I guess I guess I'll have to call out your names because I don't know, you wouldn't know who's who. But Kristen, why don't you go ahead and introduce yourself if you would?
Yeah, hi everyone. I'm Kristen Burton, and I am the Executive Director at With a Little Help in-home care in the greater Seattle area.
Thank you. And Sheena?
Hello, everyone. My name is Sheena Paler. I'm the Regional VP of Sales for LHC Group locally in Washington and Oregon, known as Assured Home Health. I oversee all of Washington State, all of Oregon State, and North Idaho at Coeur d'Alene.
And Allyson.
I'm Allyson Jenkins. I am the Executive Director at North Auburn Rehab in Auburn.
And Karen Durbin.
Hi, everyone. My name is Karen Durbin. I am the Director of Integrated Care Management, otherwise known as Case Management, at Carson Tahoe Health in Carson City, Nevada.
Thank you very much. And I, of course, am Steve Rudnick, the Chief Medical Officer of Noble Physicians. I'm going to see if I can come on the video at some point, but I wanted to start out with a series of questions talking about the continuity of care, and we can start kind of in the same order, which is, I apologize, no particular order. We're not alphabetical. I'm really just going clockwise on my screen. So I'll put you on the spot, Kristen. What impact does the continuity of care have on your business? You're in the home care environment, and I know you'll get people that have either come out of the hospital, they've come from a skilled nursing facility, or perhaps they're just living at home. But how could a lack of continuity of care create a pain point in your industry? And just wanted to hear your thoughts on the subject.
Of course, I have to go first. So I think the biggest thing for us for all of us, comes down to communication. And when you're talking about continuity of care and success, it's making sure that we're all in alignment and communicating. I look at all of us as puzzle pieces that fit together. So whether it's home health or home care, skilled nursing communities, primary care physicians, all of our information added together makes for a successful, whether it's discharge or home environment or rehab or for limiting return trips to the hospital. So for me, pain points are when we miss out on communication, when we also, all of us get busy, so we don't have the time or know what's important for the other group to be updated. But what really helps is when we can get together, whether it's virtually or in person, but and all be on the same page of what the success for our joint client looks like.
Steve, you're on mute.
Thank you. I got my video to work. At least you can see my lips moving. So thank you very much, Kristen. Sheena, if you could also share with us, and you're working in the home health environment, and I know we're kind of going backwards from hospital. We're going from home care, home health, and then moving off to the skilled nursing. So Allyson, get ready, and then to Karen. But Sheena, if you could tell us, how is continuity of care impact you and the lack of continuity of care, how might that create a pain point for you in the industry?
Very similar to what Kristen said in regards to it all really comes down to communication. If the communication is there, then the continuity is there. We're all on the same page. I think it's almost flipped for us in a way as far as our continuity impacts everyone else. So if that patient's getting the same clinician over and over, that continuity of care just makes that experience and that outcome that much better. As far as continuity when it comes to like our referral partners, whether it's a physician, a skilled nursing facility, home care, hospital, I think it just, the more we work together, the more we understand our services, communication, items that are needed. Electronic EMR systems are great if they talk. That obviously helps dramatically, and we've run into some challenges where they may not, but it really just comes down to communication and how we can help bridge any gaps.
I'm on mute, aren't I? Okay, sorry about that. Thank you. I'm seeing a common thread here for communication. Allyson, your experience in skilled nursing, I know we've worked together for many years.
Yeah. Just realized I need to take my phone off the hook. Yeah, for me, the greatest impact that continuity of care has is that, we're all afraid of that return to hospital metric that we're grading on. I don't really know how that works in home care, but in the SNF environment, the hospitals, like you mentioned, have their DRGs and pathways, and so it's getting out quicker, and so we're getting people sicker and sicker. But then again, we are under the gun for a certain number of days, authorization or Medicare, HMO, whatever it is. I mean, you still have a limit. And then you've got to get that person out. So everything is hurry up, but at the same time, if they end up back at square one, now you're responsible. So continuity of care to me is what will fit those pieces together and create maybe a smoother transition from one to the other. But everybody's mentioning communication, and I think that's really key. And I think it's probably something that we haven't done great in the past. I think if you're part of an HMO and you're all one system, I think they may do a little better job because it's, they're controlling all of that. But there's no reason why with gap care or continuity, if we put a focus on that, I don't think you have to be part of the same organization to have that same good result.
Thank you. And Karen, if you also would comment, because Karen, and I know I kind of did this maybe a little bit backwards because you're starting from the hospital and then going out to the SNF and all that. But from your standpoint in Carson City, really just in the hospital environment, how does continuity start, and what pain points do you guys see? Because you're really impacted when you do have those returns to hospital. So if you could speak to that.
Yeah, so first off, I'd like to echo what everyone is saying. Specifically, Allyson, you touched on all of the points that I was going to discuss. I think communication is, foundational. But I think from an acute care perspective, I think hospitals always think they're doing a great job, right? Until you follow that path with the patient all the way. And I think it's misaligned communication. A lot of the disjointment that I see is, we have great relationships with all of our post-acute care partners. But when you really think of what's happening, at least here in Carson City, is we're making the referrals, we have the shared EMR, we think everything's open and available, but then you have someone almost coming in from the home cares or the skilled facilities, almost, I hate to say, but from a marketing perspective. And what we tell our partners on a continual basis is, I don't need to be marketed to, I want to know how we can actually help. So it's the continuity needs to have someone that is not under their own requirements. The skilled facilities have requirements, the home cares have requirements, the hospitals have requirements, and everybody is trying to ultimately do the right thing, but we're also managing our compliance and our metrics. So I think that really what falls to the bottom is the patient, unfortunately. Even though we all have the best intent, we're keeping our eye on everything else. So it is communication. I think it's just oftentimes misaligned.
Thank you, Karen. And I'm going to actually keep the spotlight on you for a minute. You'd mentioned the word metrics, and that kind of goes to our next question, which I'm going to circle back around, kind of back around the horn. What metrics are the ones that you guys track when you're looking at discharging a patient, and what is success and what is failure in that setting?
So from the acute care side, it is return to acute care hospitalizations. It's overutilization of the ER touches, how frequently they're getting in to see their PCPs. So it's hospital-based metrics, and it all ties back to reimbursement. So I think when I think you can be successful financially, but you have to put the quality of the care first to drive those financial impacts. And when we're looking at, like you say, very quick length of stay, our average length of stay is about 3 days in the acute care, and that's a lot to swallow for the complexity that we're seeing. So we've got these patterns in place, but we're really managing and looking towards utilization levels, length of stay, readmission rates. So it's primary numbers.
Thank you. And Allyson, I know working in the skilled nursing environment, we all talk about the dreaded RTH. I remember when I started working with you back before, too, it was like 2007 or something like that, 2008. And we didn't really have that number. There was like a magic number 30 that I think we ended up hearing was the look back period, but I think the day is actually 90 days that the hospitals and the insurance companies are looking back at. But Allyson, what is the success or failure metric that you guys look at from the skilled nursing environment?
Well, unfortunately, the only metric that we really have available is the return to hospital from the skilled nursing facility. We have a lot of tools that will look at that, and we can drill down to diagnosis, a lot of different components that we can look at. There is nothing really that we have to help us to gauge anything after that. When you go to home health or to assisted living, once they discharge to a community setting, we don't a lot of times hear about it until they're back in the hospital. And then we get a call from the hospital going, oh, so-and-so's here. And we're like, oh my gosh, we just discharged him 3 weeks ago. Now we're being held accountable. And even though we're not financially dinged, I guess is the best word, like the hospital, there's no like financial penalties for us per se, but there is, because the hospital will say, we'd like to admit to you more, but your return is so high that, we really like you. However, our metrics say that you're riskier than, say, your competitor has a much lower return to hospital rate than you do. And we all know that for that first 30 days after discharge, we're responsible. I mean, that's regardless of what happens in the community. And so I wish we had better metrics to help us gauge what happens after discharge into the community.
Thank you, Allie.
Mm-hmm.
Sheena, I know it's a different environment. I'm not sure. I'm actually less familiar with the home health environment, but I'm getting more familiar with it. What are the metrics that you guys use regarding continuity of care, and what is a success in that setting and what is a failure in that setting?
We have many metrics that we have to follow up on. So everything we do is scored and looked at by CMS. Washington specifically became part of a pilot program in 2016. There was 9 states part of this program called value-based purchasing. So we are financially penalized if we have patients that either return to the hospital. We're scored on our ACH rate. We're scored on several different pieces as far as medication reconciliation, whether they're on physical therapy, and let's say we admit them and we score them at a certain point, we need to get them to their baseline. Otherwise, we're dinged for that. Timely initiation of care. It goes on, and we're star rated as well as financially rated. We work closely with a lot of skilled nursing facilities. If, let's say, we see a patient that came from them, they're failing, rather than returning them to the hospital, we'll work with that skilled nursing facility to get them back in within 30 days. We also do work with hospitals quite a bit when it comes to ERs. We utilize dispatch health a lot to avoid any preventable rehospitalizations that can be taken care of in the home. But we are heavily scored and looked at when it comes to outcome metrics and quality.
Thank you. That is enlightening. And Kristen, I know also a different environment, different set of responsibilities, but in the home care environment, what does it look like in terms of, do you guys have any metrics that you keep, and what does failure look like? What does success look like? I mean, I'm sure you keep metrics, but what are the ones that you are looking at as success and failure?
Well, that's success and failure metrics based on this conversation is something that home care is starting to understand the importance of, and educating the people around us of how we do keep track of, whether it's clients. You know, when we take on a new client, we can let our team know, and our system has a way of tracking, were they given to us from because they were discharged from a hospital, sent home from a skilled nursing, or were they continuing, care needed in the home or in a community. So we can track where they're coming to us. We can also now track, and are starting to track, things like falls, trips to the hospital. So when you talk about returning to the hospital, how many times has our client gone in the last 30 days, 60 days, 90 days? And that allows us to start the conversation with people like all of you. Karen, did you know that we are able to, have the conversation? We are able to decrease fall risks and stop this revolving door in and out of hospitals. And if you educate our clients and help them to understand that more monitored safety risk, having a caregiver there helping them walk on their own or shower on their own will prevent a fall, and therefore prevent going back into the hospital, to the skilled nursing, needing home health, that constant revolving door. So I think it's in home care specifically, it's letting people know what we're capable of doing, and showing the metrics behind it. So that means we need to track it. That doesn't just allow us to be lip service, but allows us to give an actual reason why we are beneficial in this whole healthcare process.
Makes sense. Thank you. Karen, I'm going to shift back to you for a minute. A lot of this is talking about returns back to hospital, and I call myself a recovering hospitalist, but I certainly know what it's like to be a hospitalist. I know it's changed, but there's certain things that are the same. And I have to tell you, and so I was a hospitalist up until the late 2000s, and I think communication, and this is my own little worldview, is not as good directly with warm handoffs as I would like. And something that our company actually espouses, that we would hope other providers would, is warmly reaching out directly to home care, home health, skilled facilities, hospitals. And it's something that I do have. I actually can count on really one hand for the few hospitals in my immediate area here, how many times I get calls from hospitalists, and I actually know them. They have my cell phone number. But I'm just curious, what have you guys done in Carson, Tahoe to start to improve on that, or what efforts do you think are needed to improve some of these metrics with continuity and communication?
Yeah, it is a struggle. It continues to be a struggle. Part of the challenge for us here is that when you're coming from a skilled facility, I mean, so as case management, we will meet with the skilled facilities once a month to review our return to acutes, talk about the metrics, look at the length of stay, you know, that whole overarching process that we'll do. But how it gets to the providers is very broken. We've implemented practices where the providers at the skilled facility can initiate a call to their counterpart here, like, you know, these people are essentially in the same group and oftentimes don't even know each other. So they can reach out. Some of the challenge comes when they're sending from the skilled facilities. You know, they'll enter through the ER. Our ER group doesn't have admitting privileges, so the hospitalist hasn't even been assigned yet. So that warm handoff is going through the ER doc and then third party back to the admitter when they come down. So I think there's disjointment there. So there's definitely opportunity. We're working a lot on an initiative to involve nursing, but you know what we'll see frequently, which is unfortunate, but you know, they come with this giant packet from the skilled facilities, right? They'll be up on the floor and then here comes case management digging through this thing 2 days into the stay, and there's robust amounts of information in there. So streamlining that would be great, but all organizations have a different infrastructure and it is challenging for those docs. You know, I understand they're taking care of, like, you know, up on the floor and then they're running down to the ER to do an admission, and it's kind of one of those things, just that continuity again, circling back, that everyone is concerned with their own individual metric and patient gets lost, unfortunately, just through simple tasks.
You're on mute again.
Yes. So thank you, Karen. And I was going to direct this to Karen, but anyone else who knows the answer can chime in as well. Does anyone know of any platforms have you explored any platforms for communication to unify some of these communications or to bridge some of these EMRs or anything like that? Has anyone, Karen, has Carson Tahoe done that, or has anybody else seen anything like that?
We use our Epic module. All of our post-acute care providers have access to Link, but dependent on, which is how our referrals go out, but dependent on how long they've been with the post-acute care partner, they can't necessarily send a message back to the attending provider. So while the EMR is loosely linked, I think it, you know, if not everyone has the same capabilities, which it sounds like you guys are all experiencing as well, it's great, but not that great. It's like a Band-Aid.
Yeah. Allyson, anything that Cornerstone has been working on, or anything that you've seen in your experience to unify communications?
You know, I haven't. I don't. It's like Karen said, there really is no good system. I mean, even if you're hooked up with Epic or one of the, you know, there's like, I think 3 big ones. It's so limited in what it can do that there's just huge room for improvement in that area. Certainly way above my pay grade anyway. I wouldn't even know how to start that, but it certainly is. It's very much a need, and some company software, someone should come out and figure it out, because if we had that set up where we had really great communication, because most of the time, like take Epic, for example, it's mostly just your discharge planner communicating with the SNF back and forth. There's not anything that integrates. I mean, you have access to whatever they put on there for you to look at, but there's really no way to have a lot of communication with anybody outside of that, or there's not a lot of back and forth, say between even like the therapy departments. If the hospital therapy department had something where they could access the SNF department, like if Epic had something where that would even be available. There's so much room for improvement, and it's not that it absolutely can't be done, it's just not as user friendly. And it also, you know, a lot of the programs are limited by what the company buys into. They'll have a basic package and the next tier and the next tier. Well, you're only as good as who you're trying to communicate with has bought into. So there's so many nooks, crannies, and limitations that it's a very, very imperfect system at this point.
Yeah, that's for sure. Sheena, any experience with any unifying communication tools or anything like that in your industry?
So similar to what both Karen and Allyson said, as far as it's there and available, but yet broken. However, on the east side of the state, we do have access to a large hospital systems EMR, and we're able to communicate back and forth with the primary care physicians, and it has made a huge difference. They're able to communicate on orders, which we get timely, which can impact a rehospitalization. We're also able to connect with their healthcare navigators, which are those nurses that are working with high-risk patients. And our ACH rate has dropped to 9%, I think, in that market. And I really feel like that is a huge reason to why. So there's definitely, like Allyson said, so much opportunity for improvement.
Thank you. And Kristen, just curious if there's anything that you guys have used as a unifying communication tool or a way to kind of fix some of these miscommunications.
Now, we are at a different level than all of you in regards to what information is important to us a lot of times. But our most successful when partnering with skilled nursing or hospitals or home health is a good old-fashioned care conference. Just having all together in one place and talking it through. Because oftentimes, even if you send us all the paperwork, the discharge paperwork, or allow us to get our hands on all the information, for my team members to sift through that, they really only need a portion of what's handed to us. And I understand that it's not up to anyone else to try to filter that information and pull out what's important to us as an in-home care company. But getting together and just talking it through is really our number one success.
That makes sense. So I want to shift gears and talk a little bit about one solution that we've used in our business. We've as I've shared with you before, I was a hospitalist. I worked in post-acute care and skilled nursing facilities and long-term care centers. We had a small office, and we've worked, this is all prior to the pandemic, in assisted living facilities. And then during the pandemic, we piloted a program doing some post-acute care work through telehealth and telemedicine. And so we had seen before the pandemic that there were home health agencies and some people that were leaving skilled nursing facilities that didn't have primary care providers. They didn't have a face-to-face provider in time to get services started, and they didn't have follow-up. So we wanted to fill that gap. And originally we were talking about doing it in person and opening up some small satellite offices, but during the pandemic, we actually piloted a program where we did this throughout the state of Washington and now in Nevada, where we're taking care of people that are freshly discharged from the hospital from skilled nursing and who are home health patients. And then of course we have some patients that are home care patients too, or that they need home care eventually. So because we have not seen a unifying communication tool, and we've seen a couple, and we were introduced to some platform that was almost like a Facebook, but it was like a closed network, and if you were connected to it, it was almost like a kind of an insulated private Facebook for home health and home care and providers. It was an interesting idea, but it's not a huge one. And I think there's some companies that are working on that. But to me, I think you'd all kind of touched on good old fashioned communications, good old fashioned care conference. And that's what we also choose to do. So with gap care, and I want to go back to Karen, this kind of care where you have somebody who's kind of quarterbacking the care of the patient, coordinating their follow-up appointments and things like that. What has been your experience at Carson, Tahoe, whether it's with us, of course, you say nice things about me, but but in general, with that kind of care, and how has that helped? And do you think how else might that be developed? In the future to help that continuity?
I think that there is an excellent space for that to occur. I don't know how it is up in Washington, but access to care here is challenged. It's hard to recruit providers. So what we're working on right now is the time for the time until third next visit, I think is how they're referring to it, to a lot for, the cancellations kind of get overlooked, but the third next visit needs to be within 7 days, and then we would think there's no need for that gap care, which there's a lot of opportunity in our region. So the patients are loving it. We have had a small sample size, but it's from my perspective, it's very beneficial because it is that one level of oversight that telemedicine doesn't have, like if you're following my patient population, you don't have specific metrics that you're trying to meet outside of making sure the patient has access and has appropriate care and has follow-up and coordination of resources in the home. And I think when patients leave the hospital, we're done. Even if we have transitional care nurses, they may be in the clinics, but then those are very clinic focused. So what about all of the rest? Then we have transitional care nurses in our home care, but they have, again, their own set of requirements. So I think to have the one constant that's the thread, in my opinion, works very similarly to how case management in the acute care setting works. It's just coordinating everything, and probably I would imagine the same in home care. Just one constant person that has an individual focus, which actually is able to be the patient without getting clouded with everything else.
Thank you. And Allyson, from the skilled nursing setting, I know, we used to sometimes struggle getting people to follow up and connecting them with different services. What has been your experience in that area, and any comment on that kind of, filling that gap?
Yeah, one of the, it feels like that the system, even though we try to change it, really is very linear. I mean, it's like a ladder. You've got the hospital, then you've got the SNF, and then you've got home health. And then if you fail at the bottom of that ladder, you go all the way back up to the top and you start over. And a better system, and where I kind of see gap care, is that I'd rather see that in a circle with gap care and the resident or patient in the middle, and then spokes going out where, and someone alluded to it earlier, I think it was Sheena, about how when someone starts to fail, you don't necessarily have to go to the ER or back to the hospital. If that person's been discharged within 30 days, going back to the skilled nursing facility is very easy. It's a very easy readmission process, but it isn't used that often or as much as it should be. And I think a lot of that has to do with the relationship that you have with your home health provider. You really have to kind of establish that, because everybody has to change their way of thinking. But if you have gap care, sort of alongside that patient, then gap care can help navigate that. Not only maybe catching someone before they fail, but when they start to fail, what is the best option here? Is it bringing home health back in? Is that an option? Is it going back to skilled nursing, or is it to the point that they do need to go to the hospital and be admitted? And I think if we could come up, if we functioned on that circular, I think we would see much healthier, happier people, out in the community. A lot less. I even think it would diminish having to even go to anybody else in the circle. First of all, it would keep people at home healthier because you can catch things much earlier. But then if you did have a problem, then you've got somebody that already knows and is thinking, okay, what's the best option for this person versus hospitalization? And sometimes that's going to be inevitable naturally. But, if you can say that we tried this and that, I think everybody's metrics would be improved, and the resident wouldn't have that role. I call it resident. Sorry, I know it's patient, it's resident here. You're in a nursing home, but they wouldn't have that roller coaster ride through healthcare that so many of them experience now. And just the vicious cycle of going back to the hospital, coming back to the SNF, and then going back to home health. It would just be a win-win for everyone, I think.
Thank you, Allie. And I want to just add to that a little bit. I had the unique experience when I worked actually at North Auburn Rehab with Allyson, and we've since left and come back. She's come back over there. But the experience that I had was I was the medical director over there years ago. We had an office down the street, and I also took care of some assisted living people literally across the parking lot where I actually had work now as well. And I actually experienced being that kind of the center of the wheel. And I moved people from my office back to the skilled nursing facility, from the assisted living facility, back into skilled nursing, back to assisted living, back home. And so kind of in a little microcosm, I experienced this years ago before all the pandemic. And so, and I think part of what will be important, at least in the skilled nursing environment, in my opinion, is that you do have to have buy-in from the medical director team and from the providers in the building. They have to be able to communicate with whatever providers are sending them back. And if they were closed to that idea, like I remember being a hospitalist and doing direct admissions, I did more of them than most people because I was working night shifts and swing shifts and everything. And it saved, maybe Karen could speak to this, direct admission costs less than coming through the ER again, right? I mean, if you have somebody who comes back to the hospital. So yeah.
It does.
Yeah. So anyway, my thought is, kind of aligned with both Karen and Allyson, that communication and gap care could help with that process. So Sheena, I know your experience has also been unique during the pandemic, and we've been working together now for several weeks, I guess months really, and just wanted to know your experience with that and how has it changed things, and how is it and what do you think are the future directions for that kind of continuity?
Yeah, it has changed things dramatically for us in a positive way. So CMS requires any home health agency to admit a patient within 48 hours of discharge from either the acute setting or if referred to from a physician. So oftentimes we will get patients that do not have a primary physician to follow, and that is a must for home health as we follow all orders. And so being able to provide that service that you provide has saved people from either staying in the hospital longer or a skilled facility or returning back. The reason why the 48 hours is because that time frame is so crucial for those patients, whether they make it or they fail. And so anything we can do to protect them from going back in is going to help. So your services have been very, very helpful.
Well, thank you. I've just been begging for the compliments, but thank you. Appreciate
Yeah,
that.
I just want to kind of piggyback on what Sheena's saying. It is very, very common for us to have somebody discharged that was just here for short-term rehab. Sometimes it can be months before they can get in to see their primary care, if they have a primary care physician. And we all know that that first 5 days are critical. The first 30, most people, if they're going to fail within the first 30 days. And there has to be something in between. If they go home with home health, we feel a little better because at least there's a couple weeks, maybe 3 weeks that somebody's going to be monitoring. So that helps break up the time in between. But most of the time, that's not the case. And around here, specifically during COVID, it seemed like home health was just slammed. And, a lot of times they would be honest and say, you know what, it might be 2 weeks before we can get someone out, or we can't take this person because we can't see them in the time frame that's required. And we were really struggling. So it held up people from being discharged and made it riskier when they were. And to have gap care, I mean, particularly in this climate with COVID, I mean, there's just a huge need.
Thank you, Allyson.
If I could just add one more thing to follow what Karen said as far as their challenges in the Reno area, is we have a lot of very rural markets in Washington where there just aren't enough physicians, or they're leaving and they're not coming back. And so being able to have that service just to meet that need has been critical as well.
And thank you, Sheena. And Kristen, I think that also, although you guys work in Seattle, I think you could speak about the industry where home care really is a great service that is going to prevent a lot of these people from returning to hospital, because you guys are the eyes and ears in the front lines of those people that are vulnerable. So if you can kind of speak to that, and also your experience for how your industry is trying to help improve the continuity. I mean, I know that's just basically what you're doing, is trying to enrich people's lives and help them stay independent in the home. But if you could speak more to that.
I think for me, one thing for all of you to know is I came from a high acuity assisted living and then also running memory care units. So making the switch to in-home care at the time, I thought was going to be companionship. As I've educated myself and grown in this industry, I'm realizing that education piece to the rest of the home, to care in general, is a missing link. I don't want to go down a path here that's too much of a rabbit hole, but when we talk about going into the hospital or needing care in between to make sure that someone's safe, that's in-home care. I mean, in-home care can be everything from 2 hours a day to 24 hours a day, 7 days a week, dealing with the oversight from a primary care physician and home health to monitor falls, wounds, catheters, Hoyer lifts, 2-person transfer, safety, nutrition. So, I mean, 2 hours a day of someone coming in, and home health is a massive piece of this puzzle. I love home health, but they're also not staying in the home. And once they're responding or trying to set clients up for success with PT exercises, or whether it's medication or therapy or whatever, OT, but our caregivers can follow through on those exercises and report back and make sure that it's happening, gaining strength or saying when there's a weakness, anticipating when an issue will come into play. So what I think about home care is it's preventative care. It's the things that are going to help with the beginning of this entire cycle. I don't want to go down this path, but this is also why I really think there should be a push for having home care in some situations covered by insurance. So Karen doesn't feel like she can't send them to a home care agency because it's private pay. And I also believe with in-home care and communities specifically, and I'm saying that from experience, is Karen hit the nail on the head with transparency of what in-home care and communities are able to do. That they're not in there just marketing and bringing you lunch, that they are saying, I can take a client, I can take this level of care, and I can do it today. Not, oh, call me when you have someone and I'll see if I can make it work. And then we can't follow through for you.
I'm so glad you brought that up about having it loaded into payer contracts with reimbursement methodology, because in that short little stint that patients are here, I can tell you 80% of the time very comfortably is, oh no, we can't afford that. And so it is that lack of recognition of seeing what really can be done. And what we encourage with our team all the time is, we always say, defer to the experts, let the home care agencies, let the ADL providers, let everyone come in here and say what can be done. Because I think a culture from an acute care setting, from the provider stance, is, you have these discussions with patients and they express doubt, they express concern, but it's really the fear of the unknown. And then we see a lot where the provider may indirectly and not purposefully at all kind of support their self-doubt, instead of saying, no, home environments and acute care environments look so different, and it's okay for them to look different. But I think that we on the acute care side, we're not great. We immediately think, oh, this is a very high level acuity patient here, there's no way they can go home. And until the culture has changed, that you start with, how do we get them home, it's just a massive rub. So acute care side, we absolutely advocate for getting in-home care covered with insurance.
Great.
Thank you very much. I'm mindful of time. I got to put another quarter in the machine here in a second, but I wanted to see, I don't know if there's anybody out there that wants to add some voice and questions, any other comments out there, any of our live participants. Well, all right, very good. I know I see it's
what
about.
I'd like to say is, I'd like to say that we can keep this conversation moving forward and have abilities to bring different perspectives and solutions to the table. I think that everybody's from a different space, which is great. And I think if we can continue together to build more voices in this group, I think that it'll be very helpful. Like, Kristen was saying, it's about transparency. And I think in some of the facilities, it isn't transparent, right? Or even what the rules require them, or how they require them to be transparent, is not the same across all different modalities of care. So I think the more voices that we can get on here, and the more we can collaborate with each other, the more that we can definitely make and be an impact for change to benefit. Because I know for myself, my mother recently had a stroke, went to the hospital. Nobody talked to me at the hospital. You couldn't go up there and see anybody. In my mind, I'm like, why are they discharging her so early? I had no idea that she had released herself until I get her in the car. And I said, hey, Mom, I'm reading her paperwork, right? And I'm like, wait a minute, what is this about? They needed to do some more follow-up work. And she's like, oh, yeah, they did. I go, well, I don't get it. She goes, well, I signed myself out because I said I didn't need any more help. And I said, yeah, but now I can't get you physical therapy. Now I can't get you home health services, because the doctor was trying to get you to stay there for the 3 days so that he could open up your insurance to so many other avenues that now is closed. And the education part. And she's like, well, nobody told me that. I'm like, well, maybe they did, or they didn't, or they did it in a way that was not, you didn't maybe quite understand the big picture of it. So here I have my mom who had a stroke, who I'm having to bring home, who now I'm like, I can't get her any help because not being a power of attorney, nobody was communicating with me. Even when the doctor came down and handed me her house keys to go into her house, at that moment, he could have said, perhaps, hey, maybe we should talk to your mom about staying another night, right? No, rather he just said, well, I think everything looks good and we'll be discharging. So in my mind, I'm thinking, okay, there's nothing going on. Not that she had discharged herself. When he says to me, oh, everything's good, we should be discharging, I'm thinking everything's good, not that it was a different story that I learned later when she's in the car, So I think that is, it's a big one, because I think of just that event for myself recently, the different landmarks that got hit. And I think had COVID not been in place, then I would have been able to be up in that room, been able to talk to that nurse, been able to ask. So I think even now with COVID, it's even more challenging for families to miss the puzzle pieces because we don't really even know that they exist.
Yeah, and that's a great point, Elisa. Thank you for sharing that, and hoping that your mom is getting better and better.
Yes.
And I think it's a good place to kind of pause where we, just to kind of round up the thought. We have a lot more to talk about. There are more discussions to have, and just so grateful for all of you. I don't want to get too sappy here, but during this last year, we're literally coming up on a year since we had all been locked down, and so many people aren't here today that were here before, and this has just touched our lives in so many ways that you can't even enumerate. And yet each one of us in our respective places has done something to help other people's lives. And all of you have done enormous work that have really made a huge difference that you never probably heard necessarily a thank you or a wow, it's incredible what you did. You prevented so-and-so from having to go to the hospital, or you've prevented so-and-so from having to stay in the hospital or stay in the nursing facility, or whatever the case may be. You helped save these people. All of these things could not have been done without yourselves and the people that are dedicated working around you. So I applaud all of you and really appreciate all of you for joining us today in the conversation, and hope we can continue more conversations with less technical difficulties. So anyways, thank you all very much for joining us, and don't forget to tip your server on the way out. Anyways, Colleen, any parting words? Colleen Swenson, our Chief Operating Officer, putting you on the spot.
Yeah, thank you. So once again, thank you to the panelists. It was a great discussion. I loved hearing all the points of views. It's definitely, as Alyssa said, a conversation that, I look forward to continuing with all of you. This session was recorded. So if you would like a copy of the session sent to you, I'm more than happy to send the link to it. Go ahead and just shoot me an email, say, yes, I want a copy, and we will get that out to you.
I will try to edit out any of the parts where you guys were picking your teeth or anything like that. I'm going to do the same for myself. So
before you close out the conversation, sorry, just one more minute. Could you ask each of the guest panelists or the guests to kind of say, what didn't we get to in this conversation? What would you have liked to see addressed or discussed that wasn't?
Thank you. I appreciate that. Kristen, I'll put you on the spot again. We're picking on you first all the time. Anything, David, I'm going to misphrase it. Go ahead and say that again.
I can, what is missing from me or what we didn't get to is how in-home care can further help you, especially knowing that I came from a different space into in-home care and what my preconceived notions were. I think it's really important for us in home care to learn what we could be doing better, and to make you not only be more confident in who we are and what it is we do, but how we can make your world easier, because you're the ones that really have this sense of urgency and then, like you said, the numbers and everything attached to it. So really for me, it's what more can we do?
Thank you. Sheena?
Thank you for the question, David. Very similar to what Kristen said. I think there was definitely a lot of good conversation, but it's just the start, right? I think this conversation will lead us to further discussions about what the challenges are and the next steps of how do we overcome those challenges. So I'm just looking forward to further conversation around everything that we spoke about today.
Thank you. Allyson?
I don't really have anything to add that they haven't already added, except maybe we all get together and create this awesome tool that communicates across every modality, and we all get rich and retire.
That's a great idea. Woo. Karen?
Definitely on board with get rich and retire. The sooner the better. But I think there's a lot of weight in, I think that, probably we all ultimately end up in the same dialogue because we share the same opinions. But I think making those feelings actionable and mobilizing some change, I think would be great. Start small, ends big. Then maybe we get rich and retire with that too.
I forgot to say get rich and retire. I'll second.
I see a common theme. I hope that's all good news for us going forward. Anybody else? Very good. Well, again, thank you all the panelists, Kristen, Sheena, Allyson, Karen.
Thank you for having us.
Thank you very much. And we'll look forward to seeing you guys soon. Thank you very much. Take care. Yeah.